I would just like to thank Neurosoft for helping out with all the technical, all the assistance, and also the patients who you will see later on after tea break, where we will have some demonstration on abnormal subjects. Okay, I understand that difficulty in understanding the English, so there's no translation, but I will try and do it very slowly. Right, so may I know how many people here in this room? Maybe there are like 15 to 20 people. How many people have tried using TMS here? Anybody else? Can I have a show of hands? No, nobody. Anyone who's tried using the TMS here? Nobody. Oh, one. Okay. All right. Thanks. So, yeah. So this is my declaration. Yeah. So today I will concentrate on some more clinically relevant TMS topics, including a brief introduction and also principles behind this method. Okay, this method is quite unusual, but it's got its own advantages and also utilization. Not a lot, but certainly a lot for research. There are some limitations that you must be aware of, and also we'll do some demonstrations before you come to some conclusion. And most importantly, hopefully we can get some hands-on try using this method on, well, maybe the patient or the subject or the normal subjects. And also, we will also take in any query, any questions you want to ask me. I don't mind, we can have a translator here who can help with, we can ask in Vietnamese also, right? And then we can translate it in English and then we can translate it back. We have lots of time. So not to worry about time, it's not a problem, okay? So because I understand it's very new to you all. So we'll just do the basics of single pulse TMS. I'm not here to cover this double pulse TMS for inhibition or some kind of facilitation kind of TMS, or as you can read, triple stimulation TMS or PET TMS or RTMS, and then the latest TMS methods, TMS, EEG, and all these methods. Today we won't have time to cover all this. We just introduce the subject, and it's just nice that many people here are not so familiar with the subject. Okay, if you see this machine in front of you, it's essentially it's a capacitor. Okay, it's a huge capacitor that charges up, and at a flick of a switch, you can actually release a current into all these coils. The coils are made of copper wires. That's why you hear a tuck sound. The click sound when you release it is because the coils are hitting against each other. And it's usually encased in, now there are newer materials, but technically they are in a non-conductor. So the material that we have is a ceramic material, right? So this is ceramic. And because, as you remember, magnetic flux passes through non-conductors. So if you encase it in a metal case, a metal coil, then you will not get anything, right? But as the magnetic flux, unlike electrical current, passes through a non-conductor, it will effortlessly pass through the ceramic coil. It will pass through your skull, it will pass through your hair, and then it will excite the brain parenchymal tissue itself. So that's the beauty of TMS. So you will feel a twitch, you will not feel pain. So you can imagine the opposite technique of electrical stimulation. You, instead of magnet, you put two electrodes there and then you hit it. What happens is that if you have a conductor, but unfortunately your skull is not a conductor, right? The skull is made of bone. But you have a conductor, and then it kind of like hits the stone wall, and if a non-conductor hits the stone wall, it doesn't pass through. But magnetic flux, it passes through. So you don't feel any pain, you don't feel any resistance, not so much heat. And that's the beauty of TMS. So when the guy in the 80s, they tried to come up with this method. They had this idea in mind that this is a so-called non-invasive way of stimulating the brain. If you use electric current, it's still non-invasive, but it's not effective because you will hit the skull, it will face resistance, and then the coil, a lot of the charges will be distributed across the head. Unless it's so powerful, like in intraoperative monitoring, when we have a train of pulses, high intensity under anesthesia, you can pass through, okay? But it's not, it's a very painful way of stimulating the brain with electrical current. So that's TMS. So you can see this coil, there are many coils. This is this is a design of coil. Later on you can see the Neurosoft coil, very nice. And it's a bit curved. And when people experiment with designs of the coil, what they did was they have the principle of what I said earlier on in mind, but also they looked at whether the coil can be accurately stimulate a brain area of the brain quite accurately. Okay, so I give you an example. This one here, the intersection of the coil is where the point of maximal flux is. So unfortunately, the spatial resolution is not fantastic. It's about 2-3 cm, maybe even more, depending on your properties of your skull or your head. Okay, and then for the round coil here, it's called the round coil here. Later you will see the coil. There's a big hole in the middle, but people think that the stimulation is right here, but it's not. It is actually around the edges of the coil. This is the point of stimulation. When you put when we put it on top of the head, you can see. So there's no magnetic flux passing through the middle here, unlike this one. Okay, unlike this side of coil, we call it a figure 8 coil. So the round coil is a non-focal coil. Another term is called a non-focal coil. And it can help activate some areas of the brain quite well, like the deeper areas. Okay. Then later on, people try to be a bit more innovative. They try to put in more current, more pulses, and then try and innovate with coil design, make the coils more heat proof. And then eventually people put in water or oil cooling system here to cool the coil. Because when the coil is hot, you won't deliver the magnetic flux that you want, and the machine will shut down. So these are new technologies. And then eventually there's neural navigation, right? And sometimes the navigation can be in real time together with the MRI images, and you can actually have a more precise stimulation. But neural navigation, you have to be careful because it can actually stimulate the point where you want it to be, but it can follow. Sometimes you can even follow as you move your head, but unfortunately, the spatial resolution of the coil, even the most advanced coils, are not fantastic. They're not like pinpoint accuracy. They are like I would say maybe 2 to 3 centimeters plus and minus. Kind of, it's not a focal area. So unfortunately, there are some limitations of TMS. And these coils can be to the extent that some people try to put 2 coils and then try and activate some parts of the brain deeper, like the corpus callosum here, maybe the corpus callosum or some of the subcortical areas. These have not been shown to be clinically very, very robust. The responses are very variable. I won't waste a lot of time showing you today. And I think the basic ones you can activate is the hand muscles and the leg muscles, small hand muscles and feet muscles. I think that's about it. And we are activating on the surface of the head. Okay, so a lot of coil designs. Okay, this is the electrode. We'll see later the electrode that we have, the sticky electrodes, adhesive electrodes. This is similar to EMG, to nerve conduction, right? Basically, you are recording a muscle twitch, right? And the most effective area in the brain that we can stimulate is something very superficial, very close to the skull, very close to the scalp, and somewhere that there is a motor response or muscle twitch. And of course, there must be the motor area, the primary motor area. Okay, and that's where we want to concentrate on. So it's good and bad, but with RTMS, we can actually activate or inhibit other areas. But with single shock TMS, where you want to have a measured response, we will show later, then obviously the motor area is the one. All right. So I just introduced the first concept of something called motor threshold. You know what's threshold, right? Threshold is the lowest intensity that you can deliver to obtain the smallest visible response. So TMS, interestingly, there is a resting motor threshold. Okay, and that refers to the lowest intensity to elicit a muscle twitch. And in research settings, you define it as such, 50 microvolts, at least 5 or 10 trials. This is a old, very old kind of standard that we have used. Okay, so this is it's actually a muscle response. It's similar to a nerve conduction, but it's evoked by on top of the brain. So active motor threshold is we don't always use it, but it's when the muscle is active. And later we'll show you when the muscle is active and you shock the brain, a lot of things happen. All right. And what really happens is that the motor threshold indicates how excitable the brain is. But if you want to compare how excitable the brain is between subject A and subject B, right? If subject A, the threshold is 50% of intensity, and subject B, the threshold is at 70% of intensity, right? Of course, subject B is a higher threshold, right? But in some patients, the threshold can be very high. It's not because there's something wrong with you or you know, but there are many variable factors that will determine the threshold. What are the physical factors? Okay, not so much age. Age, the threshold goes up a little bit, but common things include how excitable your brain is genetically determined. Some people, the brain are not so excitable, especially the motor cortex. Some people, the activation site maybe not where it's supposed to be, and you're going to move it around and find it. Some people, the skull between the skull and the motor cortex may be a bit further away and all that. So there are many factors. Then there are, of course, other factors, including medication, drugs, medication, maybe even physical states like sleep, and people even see cycles or period, it changes threshold. The threshold does change a little bit every day. Okay, so motor threshold is important. Later we'll show you how to get a threshold. And why do you need to get a threshold? It's because if you want to do something further on, like treatment or a research project or something like that, you define the intensity of that particular subject by the threshold, right? So for example, if you want to do RTMS treatment for depression, for example, right? You need to define the threshold, and you don't want the threshold, you don't want to stimulate too high blindly, and then heat up the coil, and then also very uncomfortable. The guy might shake, and you keep on activating the hand and all that. You want to be just at or below the threshold. So the threshold got many users, and you can read here. Drugs can affect the threshold. So obviously, the channels, like sodium channel and all that, has got the probably part of the reason why thresholds are different, right? And as you know, all these medications here, NMDA blockers, these also change the threshold. Okay, and later on, if you have time, we can show you what phosphines are. Phosphine threshold. So we are talking about motor threshold. There's an occipital cortex threshold called phosphines. So if you shock the occipital lobe, you close the eyes, you can see a brief flash. All right, there's a certain threshold. That's called the occipital threshold, or we call it the phosphine threshold. So most thresholds are motor thresholds to talk about, but there are other types of thresholds that we can use clinically or in research settings. Okay, so this shows you the threshold, kind of, moves slightly up with age. It's quite frequently cited paper. Okay, nobody's going to redo this experiment. Okay, it's time consuming, but this is the gold standard of what the threshold would be like over as you age. Okay, all right. Okay, now I just want to show you the direction of coil. Okay, for non-directional, non-focal type of coil, like the round coil, interestingly, if you want to activate the right side of the brain, right, the right cortex, your coil current, later on you'll see the coil current got to be flowing backwards. And you flip it over the other side, you will activate the other side, right? Whereas for the focal coil, then you need to activate on the motor strip, as close as possible to the motor strip. For the leg area, interestingly, I won't try very hard to use the 8-shaped figure 8 coil because the activation is quite difficult. The leg area, as you know from the homunculus, is very deep. So you can use the round coil, a slightly bigger round coil, and move it a bit anteriorly, like 2 to 3 centimeters anteriorly, and you can find activating the leg. But same principle, anti-clockwise on the right and then clockwise on the left, vice versa. You can try. So interestingly, this is how the machine turned out to be, and same for the hand. So the hand, like I said, you can try on the motor strip itself using the focal coil. You can also use this one. But in the leg, you move it a bit front, and then you get the twitch, as I showed you earlier on. Leg. So you move it a bit more to the front, and then you try and activate the leg. Okay, so we'll show that later. Just keep in mind. Okay, now this is very important. Okay, but interestingly, the muscle twitch, at least for the motor response, is quite interesting. If you have fairly low threshold, okay, so these machines usually go up to about 2 Teslas. If you have a fairly low threshold, or like between maybe 40-50% of 2 Tesla, which is about 0.8 Tesla intensity, and you can sometimes you can even turn up to 70-80, and in a relaxed muscle state, you can have a small muscle twitch like that, MEP. But if you contract the muscle, or we call it facilitate the muscle, you will go up like 5 times or even higher, and in the MEP will be a lot bigger. The latency, or we call it the cortex muscle latency, doesn't change very much actually, but the amplitude changes a lot. And this is called facilitation. I'll just go through tell you why. Okay, so the other thing is that the amplitude is not very reproducible. It changes, goes up, down, up, down, up, down with each successive stimulation. Okay, you can try to control it, but often, and if you put it at low intensity, sometimes the variability is more. And of course, it's individual. Not much clinical utility, but this is related to the probability of firing of the motor neuron, the pyramidal motor neuron. You can see using this method called PSTH. And that is how we are. So what I'm trying to say is that as we talk, as we do our things, we listen to lecture, whatever, the thresholds actually keep changing, and the pool of motor neurons that are activated is changing every second, every few milliseconds. And every time we shock the brain, you get a kind of variability. So to reduce the variability, you try to make measurements that are less variable, and that is the latency, or what we call later on to show you the central motor conduction time. The amplitude itself not so great. Okay, right. And then the other thing is that because the motor cortex has got inhibitory and excitatory neurons, they actually act together. And when you shock the brain and record the EMG, you can get the MEP here, but it is followed by something called a silent period. Okay, later we'll show you what it is. Interestingly, this silent period is a period where it suppresses the response, and it must be something that is activated, which is inhibitory, some form of inhibitory circuit at the same place where you shock it. So TMS not only brings in a positive kind of motor response, but it also has a inhibition as when the muscle is activated. And often when you do TMS, you don't see this because you must put the sweep to a much longer kind of sweep. Then you can see that this follows. Because most of the time you put the shorter sweep, then you see this thing, which is this thing, and you don't see the silent period. Okay, the silent period is actually a surrogate marker of cortical inhibition. Okay. Now very important. This will imply the patient, the implication to the patient. We will show you something called central motor conduction time. Okay, in my opinion, after doing so many single shock TMS over the last 20 over years, this is the most robust measurement that you have. And the central motor conduction time is for cervical cord disorders. And why do we call it central motor conduction time? It is actually a cortex to anterior horn cell conduction time. Okay, so those shocks that we have are coming about 20 milliseconds from the head to the hand muscle is cortex to muscle latency. Right, then we can subtract it from what we call it the peripheral motor conduction time, which you can obtain by shocking the neck, which I will show you later on. You're shocking the neck, you stimulate the neck muscle and the root or about the same, also about the same way, you can use the F wave, divided by 2 and subtract it off. You get roughly the same normal value, which is upper limb about 7.7 milliseconds and lower limb 16 milliseconds. Okay, don't forget, this is not cortex to brainstem or whatever. It's a cortex to anterior horn cell conduction time. Okay, so if it's prolonged, you can say that there is central motor conduction delay. That you can say that there's cortical spinal dysfunction at or above the anterior horn cell. You cannot say exactly which level it is. Okay, at or above. You cannot say. So you ask the question if there's something in the brainstem or some stroke or that. Then you got to say that you're not sure, because sometimes you have a big stroke, you have cervical myopathy, so you have a double lesion. Then you got to remember that it both can actually delay the central motor conduction time, right? And for the lower limb recording central motor conduction, it's about 16, so it's about double. So it kind of tells you that we are quite proportionate, right? So from here to the C8 muscle, we are about half the distance from here to the chorda equina, right? So 7.7 times 2, about 16 milliseconds. So that's quite consistent. So this is how fast it travels. So this probably all the myelinated fibers, and roughly the calculations about there, similar to nerve conduction. Okay, so TMS can excite the cortex. Actually, we do something like imagining or reading or talking as you stimulate. You can find that the MEP can become very big, but it's variable. It's variable. So hence the error bar, right? The error bar. Okay, and of course I show you that it can inhibit the cortex, and this inhibition can be enduring. It can outlast the duration of the stimulation by a little bit. So if you deliver one shot, it can be enduring, at least to the extent of the silent period, right? And then if you deliver a train in RTMS, it can actually be even more enduring, right? So in treatment of depression, you do it every day, you give 2,000 shocks, Monday to Friday, you do it for a month, right? The effect kind of adds on, and it might last for another month or two, then you come back again. So that's treatment for RTMS. So the effects can be enduring. Enduring in English means it outlasts the time of stimulation, right? It's enduring, right? It's just to remind you that when you shock the brain, don't forget the pathway. Okay, it reaches past the subcortical areas, brainstem, and then there is an anterior horn cell. It makes one connection here. It makes one synapse here. Hopefully one, maybe one, it can be a lot. If you record from the small muscles of the hands and feet. If you record from other muscles, I'm not sure. Okay? So, as accurately as possible as you would like to stimulate the cortical spinal tract, you are probably activating other tracts as well. Okay, so the MEP that we have from the small hand muscle, a lot of people don't know this. This is largely, I will use the word largely, not entirely. This is largely cortical spinal tract. Because people don't understand that our body is built in such a way that as we sit down or erect on our chair, or as we shift our posture, the axial muscles and the proximal muscles, neck muscles as well, are not fully cortical spinal. There are other tracts coming down. I'll show you in a while. Okay, and these are not directly activated using the coils that we have, but some of it contaminated. Okay, so you got to understand that part. Okay, so this tells you that if it is purely cortical spinal, the longest fibers, right, come down, do one crossing in the pyramids, and then it comes to one synapse, okay, in the pure state. And then you get these findings that I showed you. Okay, show you. So this is tells you that you can shock the brain as well. You can also activate the other cranial nerves as well. So this, you must be careful because some of these round coils actually not very focal. Okay, another depiction of peripheral motor conduction time, right, where you are. So the response is here, and then subtract this off, and then you get the central motor conduction time, right? So this means shocking the neck and activating the root. So where does it activate in the neck? In the root here. It activates the exit of the foramina, just slightly out of the exit of the foramina. You can also stimulate the root using electrical stimulation, but it's very painful because again, I told you, because our body is not conductor, non-conductor, but if you use the magnetic coil, it is very elegant. But the problem is, you don't know where exactly it is. So people do experiments to find out where it actually activates. Later we'll show you, when you activate the root, actually it's very constant, because there is a lowest threshold at around the exit where the root turns out. And that is the point where the magnetic flux will stimulate the root. Okay, so you need to know a bit of that as well. Okay, this is the same thing. Peripheral motor literacy and all that. Okay, this slide shows you what I mean earlier on. Right? Most of the time, in the pure situation, we are activating the cortical spinal tract. But don't forget, there are a lot of these tracts that are coming down. Okay, and they are not as cross. So how much is the cortical spinal tract crossed? Most of the time, 85%, right? 85% crossed, 15% comes down ipsilaterally, and we always ignore all this. Okay, but with electrophysiology, you can show that these tracts can be upregulated. But a lot of these other tracts, right, including the reticular spinal tract, vestibular spinal tract, these maintain posture. They actually innervate the axial muscles, the neck, the proximal muscles, including sometimes the deltoid, the biceps. You don't get a nice big MEP like those that you owe in the small muscles of hand. So you can try it later on. If not, the MEP is not small, because most of the time they are actually uncrossed, maybe half crossed, half of them are crossed, half not crossed, and then they actually are not directly stimulated using the coils that we have done. So you need to understand what are the limitations. Okay, so this is just another diagram to show you that. Right. Okay, so where are we actually stimulating? I don't really like this diagram, but this diagram is exaggerated to tell you there is arrangement. Okay, but you must remember that this arrangement is not the same in everybody. All right, yours and your neighbor is not the same. All right, some are more on front, some are more on the back, some are bigger, some are smaller. Maybe you speculate you're a piano player, the representation with fingers may be bigger, maybe, don't know. Right? Can you show it with TMS? Maybe. Right? But one thing for sure is that the knee or the leg or the foot, which we record, is unfortunately very, very deep inside. So you need the round coil to activate it. Okay, so the H-shaped coil, you have a bit of a problem because you're only activating this portion here, the motor strip. Okay, what about anterior to the motor strip and posterior motor strip? I don't think these coils are so accurate to not to as well. So some of the premotor area, which may also supply neurons to say some of the more proximal muscles, axial muscles, reticular spinal tract, vestibular spinal tract, may also be activated. You can contaminate the response. But don't forget, you're actually trying to isolate the response by recording, not from all this. You're recording from the small muscles of the hand. That is as pure as cortical spinal as you can get in the human body. Unless you're built differently, it should be that way. Okay. Okay, so just what I said before, this area, you put the coil, you're trying to isolate this part here, but behind, there are connections coming forward and then backward and then supplementary motor area. And in fact, some of the vestibular spinal tracts are around here, maybe even be further front. It depends on all of us. It depends on who you are. Different. It's very different. Okay, so this I mentioned already. Okay, so I just mentioned. Okay, how do you measure the silent period? Okay, so a silent period maybe about 70, 80 milliseconds, sometimes as long as 120 milliseconds in length. We measure it from the point where the EMG is suppressed. Some people measure the silent period from here to here, but I prefer to measure it from here to here. And because it can be variable, we want to average a few and get an average response, or at least get the shortest response, something like an F wave, right, or whatever. And you can actually look at the silent period following this. Okay, so cortical silent period, very difficult to get in other places, but they have been recorded in facial muscles and all that, in some patients. But in most subjects, the best success is in small muscles of the hand, right? Try to don't be a cheat by activating the EMGs very little. Try and activate it. Make the subject push all the way, right? Either by opening the hand or pushing upwards, and also use as high as intensity as possible until the silent period doesn't change. If you cheat by using a low intensity, you may not really get a silent period or a very reproducible silent period. Okay, clinical utility of silent period, we'll talk about this later. Okay, so mechanism, probably inhibition, GABA. GABA has been implicated. They've used experiments directly, indirectly show that GABA is correlated with silent period, the GABA mechanism. You can actually get silent period on the ipsilateral side as well. That means you, let me show it to you. So this is ipsilateral. That means you, instead of stimulating the right side and recording on the left side, you actually stimulate the right side and record on the left side. And this is a reflection of the transcallosal conduction time. So it is delayed in some situations like demyelination or that. In clinical practice, we don't really use this, but just to tell you that silent period can be activated on the ipsilateral side of the activating muscle as well. It can be recorded bilaterally as well, by the way. You have two channels, EMG, you can look at it. Okay, this is an experiment to show that we can actually look at even the threshold of activating this ipsilateral silent period. So anything you can measure threshold. And this shows you the core direction in activating the silent period. Is it where should it be? Posterior, anterior, posterior? There are different people, slightly different direction. So what does this reflect? It reflects how you are wired in your brain, how your inhibition and facilitative neurons are interrelated, and not everybody is the same. Okay, this I went through. Okay. So root stimulation for central motor conduction time. Either you can use the F wave or you can use the root stimulation. Root stimulation is simple. You use the round coil, put it over the small muscles of hand, C7, C8. So C8 or the T1 root here, you activate and get a root response. No need to facilitate. This is a peripheral stimulation, or over the L5S1. So later we can try that. All right. Okay. Now for focal coils, there's something called motor mapping. Okay. And later we can show you using this morning we tried it. It does work with the 8-shaped coil here, the figure 8 coil. Quite nice. Most important, you must locate the center of gravity. And then you must draw a grid or use a cap and map it. So first you find what you call the optimal position or center of gravity. So what you do is you go to the most likely area, which is for the left hand, the right vertex 4 centimeters to the right, and then 1 or 2 centimeters anteriorly, and look for that spot. If this is the spot that gives you the largest motor twitch, then that is the spot, and move it around there. Okay, then this one, if this is the spot, then you construct a grid around the spot, right? And the grid should be 1 centimeters apart. No point making it smaller. All right, 1 centimeter is already very generous because I don't think these coils are so focal as to go below 1 centimeter. And you can actually map this motor representation of the small muscle of the hand or any other muscle. But I told you for the reason the small muscle of the hand is the best because it is physiologically it is wired as to fit nicely into the cortical spinal tract activation. So mapping can be used nowadays with neuronavigation for pre-surgical planning for brain tumors in conjunction with functional MRI and all that. Some hospitals use it. I don't use that very much with my neurosurgeons. But this is one example. So if this is the optimal point, right? You construct a grid around it. You can make it bigger. It can be 9 or it can be but no point too much because over the periphery you cannot get the muscle twitch. Right? So best twitch here, 1 centimeter here, 1 centimeter below. And this is how you get it. This is an experiment that we did a long time ago. We actually these patients over periods of several weeks, we actually looked at the map size changes. So they actually become bigger and bigger and bigger. And then over the period of motor training, and these numbers basically show you how big they are in millivolts. This is just one example. You can come up with your own example of what it is. And this is another software that can show you the change in the map size. This is a paper that we published some time ago on how the map size changes after cervical cord surgery, cervical spine surgery. So before, in normal people, it's quite small, the representation. Then you have myelopathy, it becomes bigger and bigger. Then, 3 months after surgery, it kind of normalizes a bit. But this is another way of looking at it. You can look at these bar charts, pre-surgery, and then after surgery, the map size comes back again. So this is using motor mapping and normalized to the MEP in millivolts. This is recording from the small muscle of the hand. I won't try it with other muscles. It's difficult because it's contaminated by other tracks, but this is one paper that was published in quite a while ago. Okay, so to summarize, we'll show these thresholds. First of all, the threshold. Secondly, the central conduction time, variability of MP, silent period, bit of mapping, ipsilateral silent period, or we call it transcallosal conduction time. We won't have time to show these paired stimulation or train stimulation, or we call it RTMS for today. Okay, this one we can show later on peripheral magnetic stimulation, and one we can also show if there's time how to activate the facial nerve. Maybe later on we can show, if you have time, activate the facial nerve over the base of the skull. You can activate it around the exit of the facial nerve at the stylomastoid foramen, and you can actually activate the other areas, including not only the nerve root, but also the plexus, lumbar and brachial plexus. All right, because of the property of magnetic stimulation. The big problem with Erb's point activation or lumbar plexus activation or the groin area is not the pain. It's that you don't know where you're activating. Okay, so you don't know where to draw, and then you can't measure conduction velocity because you don't know where you're activating. But you can show that this can be done. Okay, so facial nerve activation. Be careful because very short latency. You can be contaminated by volume conduction, blinking, and other reflexes in the face. But we can show it to you. It's a lot less. Less painful than the electrical stimulation for some people. Okay. So this is actually one use, and actually we actually did a paper long time ago on activating 4 areas and making a recording on the nasalis muscle. If you have time, you can show this nasalis muscle on the face. You can stimulate the brain. You can actually do the brainstem stimulation. I'm not sure whether this coil can activate the brainstem. If you have time, you can try. You need a bigger cone, double cone coil. And then, of course, the stylomastoid foramen, and then also preauricular on the face. So 4 areas you can. Actually, preauricular, it's best to use a normal electrical stimulation. Okay. So recording is ocular. This is one way we demonstrate that we can actually activate the facial nerve close to the brainstem and the facial motor nucleus. So a lot of people say that, oh, I think you are actually activating the post-auricular region. Okay, and you can also do the tongue. Okay, this shows you that it's a bit different. The brainstem, actually, the response is different. It's a lot. The latency is longer than the stylomastoid foramen. And then, of course, on the face itself, you can actually use normal conduction. You can use normal electrical stimulation. So facial MEP from the cortex, quite small. And same for cortical bulba as well. You can use it on the tongue, like I show you that picture. You can make a recording of the tongue. I don't have the gadget here today, but there are tongue clips that can clip on the tongue. You can twitch. And again, the 4 areas, all right, cortex, brainstem, the occipital skull, neck. Okay, Maybe for the junior classes or the tongue, a bit more difficult for this area recording. Okay, so hypoglossal. Yeah. Okay, this paper was published more than 10 years ago. Shows you the all the responses here again. Quite nice. If you have time, we'll try to activate that. Okay, same thing. Yeah. So this is a patient that had some kind of central demyelination, and then we showed this. Okay. Right. Okay, the second part of the talk, we're going to talk about the utility of this method. Okay, apart from RTMS, which now has been FDA approved for treatment in depression, migraine, and latest OCD, obsessive compulsive neurosis. These are FDA approved, okay, for the device. And so for single shot TMS, I think the most useful is for central motor conduction time in cervical myelopathy. We know very well that in Asians, our canal, cervical canal is very narrow for whatever reason, genetics or whatever, and often the narrowing of canal predisposed to myelopathy. Okay, and we're talking about spondylotic myelopathy. So we know that a lot of this myelopathy actually encroaches onto the cortical spinal tract, the motor part tracts. So that's the reason why SSEPs have never been very sensitive. Right, I'm sure you've seen patients do SSEP, bad myelopathy, SSEP is normal. Even, you record from the leg, much longer tract. So you need to find some way to look at the anterior tract, right? Anterior pathway, right? Okay. So not so much as actually determine the direct level of compression, but more the prolonged central motor or very, very prolonged, increased kind of central motor conduction time. And recently it's been shown that they are correlated with a lot of things, radiologically, including the AP diameter, flattening of the cord in MRI, and then lots of things. So a lot of research on this stuff. So we were one of the first ones to put a large series on this, and we continue to use it every day. In fact, we have like 5 to 10 every day this period. The rest of the TMS users are more research-based, but this one, you have it every day. And as you know, I told you earlier on, the motor mapping, it can show dynamic changes before and after surgery. Actually, it does. It is something quite real. It's shown in functional MRI as well. So if you have a chronic myelopathy, quite interestingly, the motor map changes. Very strange. So there is there's a retrograde kind of change in the plasticity of the motor cortex in spinal cord disorders, spinal cord demyelination, compression, even tumors, and trauma. Okay, so this is quite well known. And CMCT has been used to screen as well, and this method of calculating CMTT actually corrects for the peripheral motor conduction time that is seen with radiculopathy, which may occur in addition to myelopathy in many patients. Okay, so we can remember that. So this is cervical myelopathy, different forms. This is radiculopathy. This is herniated disc causing radiculopathy, and this is basically central canal stenosis, and then maybe myelopathy. So sometimes you see the MRI, it doesn't show very much. But you're not sure. Sometimes it shows compression, but it doesn't affect the cortical spinal tract. I'll show you some examples in a while. Okay, this is from a paper published a long time ago, 2008. And it shows you 4 different classical scenarios. Fairly normal kind of cervical spine, with just a little bit of this bulge, not really touching the cord. Type 2, touching the cord, but not compressing it. So I call it less than 20%. Right? And now we know that the AP diameter actually figures in this, right? And then this one shows compression. And then the last one is severe compression with a signal change inside the cord. You can't show very much. There's usually a white dot here. So these are the 4 scenarios. All right? So this is the worst scenario, right? So in the first one, you get quite a nice MEP, reproducible. Second one delayed, the third one hardly seen, fourth one absent. So what actually happens is, perhaps, I don't know what really happens because this is not new conduction, but perhaps there's some desynchronization of the descending volleys, cortical spinal volleys that come down, which result in a very dispersed kind of desynchronized MEP, and also delayed latency here. So this is normal subject, and this is a patient with a myelopathy compression at a single level. So this is the figurative depiction of it. Something like this. Not sure. We don't exactly know what happens, but it's very sensitive. So we can even differentiate this and this. And later on, when we do MRI, we find that actually this patient has fairly small compression, not that much, but there's delayed central conduction, CMCT. Okay, so CMCT. These are the papers you're interested in. They're all very old papers, but they're a very large series, a few hundred patients. It shows very high sensitivity for even mild compression, and it's well correlated with MRI. So in our hospital, we tend to they tend to send patients for screening before MRI. So some of the patients, they had MRI for lumbar spine, they think that, oh, I have neck pain and all that, older patients. And they say, okay, well, instead of MRIing the whole spine, we send you for TMS and then see if there's anything. TMS is normal, they may just watch the patient and do some physical therapy or some symptomatic treatment. Okay, yeah. So this shows you that MEPs can be obtained from other muscles, including pec major, and actually they can be delayed. So pec major has cortical spinal tract. Cortical spinal tract. This is an old paper of mine. And then this paper tells you that the upper limb, FDI, first dorsal and CMCT, it can be independently used as a predictor for good outcome in cervical decompression surgery. So if it's delayed, we tend to recommend that the patient will go for surgery. But I think this kind of paper you should be careful. It gives the surgeon an additional need to tell the patient you should go for surgery. But ultimately, when you do cervical decompression, what is the main thing? You are actually buying insurance for the patient, right? You're buying insurance to ensure that for the next 10 years or so, the cord will not be compressed by further, because you're opening up the stenosis, the cervical stenosis, and keeping it open. And in the event that if there is a twist or a traffic accident to the neck, then you are buying insurance that you won't further injure the cervical cord. That is what is the main thing. All these things about prediction, yes, it is delayed, you have a good reason to go for surgery in fairly early, but most important, you're buying insurance for the time to come. Okay, if the patient has cervical myelopathy, already has changes in the cord, doing the surgery is not going to help. It will not make the recovery of the cord symptoms better. So if you have a patient that comes in with already some bladder bowel problem, walking spastic and all that, by doing the surgery, it basically prevents further injury, but you should tell the patient that it may not actually cure the myelopathy symptoms any faster. Okay, so this is just to show you that the yield from that. Okay, so this is what they do. They cut open here, right? They cut open and then they free up the spinal cord. But there are foreign bodies last time they used titanium plates, some use bone graft. Nowadays there are other types of joints, silastic joint implants and all that they use. So actually it's still about keeping the space open, right? So when we demonstrate CMCT, we are talking about that. So again, just to revise, the office utility of TMS in cervical spondylotic myelopathy. What is that? What are we talking about? So before surgery, surgeons come here and they want a baseline documentation of cortical spinal dysfunction. So, okay, CMCT delayed by 5 milliseconds, something like that. They want that. That's one possible use. Another possible use is unsure MRI. You know, the type 2 and type 3 one. You're not sure, you know, the compression is a bit there, neither here nor there. MRI is in front of you, but they want to see if the cortical spinal tract is damaged. It doesn't look at the other tracks well, but at least the cortical spinal tract, so they ask for that. Another possible use is post-operative documentation of cortical spinal dysfunction. So many of these patients, they come here and they are not walking well, they have a lot of pain, but they say, oh sir, 5 years, 10 years ago, I have had a cervical spine surgery. It's not better. I went to see my orthopedic doctor and I did an MRI and there is spinal cord injury, old injury and all that. You know, so why is not better? So surgeons say, oh, you know, let's the decompression is done, the canal is wide open, but we want to document your cortical spinal injury. So they send for this. So this is one possible use. Now, earlier on, I said screening for cervical myelopathy. So some patients come in with a bit of neck pain, and then they say, oh, hand numb, you know, weak, and all that, you know, very non-specific. Some of them have migraine, even I've seen cases. Migraine, you know, weakness, sometimes numb, you know, all sorts of things, neurology, you know, right? Then they come and say, okay, come and do a TMS. It keeps us very busy, screening for cervical myelopathy. Put it in inverted commas, screening, okay? Localization, okay, can you localize? Very difficult, I told you. It can actually tell you the delay from C1, the C8, T1, or anterior horns all the way up, but it can't exactly tell you, is it C7 or C6 or C5? Because as I told you, if you put it in other muscles, and you know, they are not necessarily cortical spinal. So I will be careful about localization of the level of lesion. Okay. Differential diagnosis. Why differential diagnosis? So we know that CMCT can be delayed. Later on, I'll show you in many conditions. Right? So sometimes you show that CMCT is abnormal, you need to go back to the original person who referred the case to you and ask whether is it the spinal cord or something else on top of it? All right? Because sometimes after doing MRI, I say, oh, you know, the MRI looks normal, but your CMCT is delayed. What causes the delay? Then later part of the lecture, we'll talk about that. Okay, and then the other things like cortical mapping, but most important, cost benefit. One of these sets of coils and machine costs about $100,000. Okay, are you going to invest $100,000 if you like private hospital, right? You have an investor, you can buy it, but in the government hospital, are you going to invest $100,000 for this kind of utilization? Okay, or perhaps you can build in some research use. You know, if you're in a university or academic institution, you can build in some research use and some service. Okay, that kind of justifies the expenditure for 100,000, maybe, perhaps. Okay, so all this comes to my mind. All right. So, okay, motor neuron disease. Okay, is there a clinical utility for motor neuron for TMS in motor neuron disease? I'm really have a lot of reservations because CMCT alone is about only 10 to 20% sensitive. So, for example, you know the LS criteria, you have motor neuron disease, you have history, and you scan the patient, it's quite okay, you know, no stroke or anything else. You do the nerve conduction EMG, and it suggests to you it is motor neuron disease, right? So you want to see if there is upper motor component, right? So one way is to wait for the upper motor signs to develop over time. But some people argue that TMS can do it, but unfortunately, I think it's not very sensitive about 10-20% of the time. Any other time. If you do it much, much later, maybe you can have a slightly higher sensitivity for the upper motor part. But apart from that, not really. But in research, there's a lot of research going on. So like people have looked at silent period and also trying to differentiate it using recording from the neck, above the neck, or even other TMS related methods like triple stimulation. But where do I use it in the office setting for ALS? I used it in my own patients who I think may give additional information for upper motor involvement, but I find that it's only about 20% sensitive. And it is not surprising, right? It's exons die, right? Exons die doesn't mean that, the central conduction is delayed. So you ask yourself, what about MEP? It's amplitude. Okay, amplitude unfortunately is very variable. So the intrinsic variability reduces the sensitivity of the MEP amplitude. Dementia also talked about, in general, it reduces threshold. So in demented patients, the brain is a lot more excitable as a large group, right? So these are some of the more recent studies I summarized, like a multi-center study, and then they actually tried to use various TMS parameters, which I have no time to go through today. Intracortical facilitation and short interval cortical inhibition, SICI, ICF measurements to help differentiate Alzheimer's disease from controls. But if you look carefully, what they're using is a complex parameter. That means you're using a scoring clinical, TMS, imaging, and whatever. And then from that scoring, you retrospectively review the result and see how sensitive it is. It's not awfully sensitive, but it introduces a lot of parameters. Once you have a complex parameter, you include a lot of things. The more things you include, more chances for inaccuracy. So you must be very careful. So most of these studies are using index or combination parameters, using various parameters. And so nowadays you know that in Alzheimer's disease or that you need more data. In a research setting, you will need imaging and maybe perhaps even some kind of biochemical changes. So TMS itself is not enough. So what about other neurodegenerative diseases, SCA or MSA? I find MSA a lot better. Actually, in patients with MSA, I find the central conduction time delay to be a lot more sensitive than even ALS or motor neuron disease, actually. Quite interesting. And can we really differentiate different types of SCA? I don't know. I doubt so, but it can help to say that cortical spinal tract involvement is there in neurodegenerative disease. Okay, combined lesion. What I mean by combined lesion, this involves combining the TMS that we have with the brainstem stimulation using this kind of coil. I'm not sure whether this one can do it, but we can try if we have time. It is similar to what we did. We stimulate the brainstem and subtract the central conduction time, which is cortex to T1 conduction time from this. So if the patient has something above the T1, then this will be taken care of. So let's say this patient here has got a stroke and a cervical myopathy below, right? Then you can actually look at this. But then again, you need controls. You need normal controls. That's the thing. This basically shows you that you can stimulate, this type of coil can stimulate the brainstem and get an MEP, but then you need normal controls. Whereas the central motor contraction time that we have, the 7.7 and 16 milliseconds, that control is very well established in many studies. Okay, MS. Okay, in some centers, MS centers, they have used follow-up TMS longitudinal measurements to correlate with scoring, MS scoring. Okay, and some studies even say that you can predict the EDSS scorings. Okay, but what is the clinical utility? I'm not sure. I think for MS clinical is important. Quality of life is very important. So psychosocial status is very important. This is a small addition to what we have that is known about MS. In the research setting, well, it gives information on maybe eventually using it to select some kind of treatment strategy or rehab strategy, but we're not there yet because the data is still not very, very clear. Parkinson's disease, most studies show threshold not change, and There may be discordant findings as well, you know, some say high, some say low. A lot of these movement disorders, you're not sure. And even the silent period, some say it's shortened. It may be followed, it may be prolonged by medications. And it also changes with the on and off period. Again, I won't use it in the clinical setting or not in even in hospital or in the private sector, private practice. Not sure how to use it. So in the research setting for movement disorders, dystonia, lots of studies on this. RTMS for dystonia started from these studies which actually demonstrate that the excitability has changed, actually, and from that on, they justify using RTMS for small clinical trials on treating Parkinson's disease, gait disorders, and movement disorders. Epilepsy, it's a big talk on whether it's safe in patients with seizures, right? People have tried to use thresholds and TMS parameters to be a diagnostic biomarker in epilepsy. So far, not much success, right? And the utility in actually looking at the physiology of as a change of cortical excitability, rather than just a single biomarker of whether the patient is epileptic. I think we're very far away from that. Migraine, FDA approved for double shock for treatment of migraine, but lots of studies on TMS. But all the studies, as you can see, this is even my own paper. Shows that it's conflicting on excitability because migraine is essentially a time over time fluctuating complex, and it's also variable, location centric, and depends on the phase on the migraine, even menstrual cycle. So migraine without aura, perhaps silent period may be shortened. Migraine with aura, depending on which phase of the person is in, maybe increased excitability. So with phosphine thresholds, you have time. We'll show that later. We can demonstrate it on stroke. A lot on RTMS, but essentially what it shows is that there's a lot of interesting information that's been shown, but essentially you have stroke affecting the right hand, that means the left cortex. What happens is that the right cortex, it's hyperexcitable. And this hyperexcitability crosses the corpus callosum and inhibits the other cortex. So it actually makes the paretic hand a lot worse. So TMS has shown this, and people have tried to use RTMS to suppress the other cortex, right? Using slow frequency RTMS. No conclusion right at the moment. There's no success, no FDA approval on the horizon. It may take a long time. Okay, and then functional disorders. What am I talking about? Functional disorders. Functional disorders is not in function, but actually disorders that are psychological, right? So sometimes it does have a little bit of utility, but the limitation is that, as you know, the method that we're using is largely cortical spinal. I've said it many times. It only looks at cortical spinal integrity. Increase in MEP duration has been, voluntary contraction has been reported in stroke controls, and these are like very, very soft kind of use in paretic patients. And motor imagery we'll show later can also be used in these patients. But the positive changes that you have are not by itself diagnostic. You still have to go back to the clinical and psychosocial aspects of these patients with so-called functional disorders. So this kind of gives you a little bit of information, a little bit more of information. Lots of research applications we won't use today, but largely mapping, disruption of cognitive tasks by inhibiting a particular area, training, changes with drugs, new drugs, especially new drugs that are on development, how much it changes, sometimes whether they have seizures as well. new epileptic drugs they've tried using this. So this is a summary of the simple summary of the changes. This paper just came out. I'm not sure whether it is on. I think it is on. Maybe it's on. I'm not sure whether it's on open access. Actually, I'm one of the co-authors. This gives you clinical, mostly focusing on clinical diagnostic utility or TMS in disorders. It gives you first part. It tells you about the principles, some of the parameters, a bit complex, but it summarizes the latest data. And the second part summarizes a little bit of what I went through just now on the disorders that we use TMS. But if you ask me very frankly, cervical myelopathy, CMCT, is the most robust and most useful. Whether you want to pay the $100,000, I'm not sure. It depends on your investment, right? And all that. Okay. The last bits I'm going to talk about safety. Okay. RTMS, there are quite a few papers on RTMS affecting seizures. There's also even RTMS in patients with seizures on paper. And even in RTMS, it is shown to be safe. So single pulse TMS is extremely safe. All right. I've probably done like more than 10,000 of these. I've not seen, today I've not seen a single seizure on the table or anything. Okay, so it doesn't really, the effect is very, very transient. And most importantly, you must build into your system to check all this and make sure there's no pacemakers. But if you ask me, if the patient tells me he has epilepsy, am I going to do CMCT on the patient? No, I say no, because it is a risk-benefit calculation, right? So what you show that the CMCT is changed, right? And then the patient has epilepsy. Why we have a fit? Okay, the patient is unlikely to have a seizure when you're doing the TMS, even if it's epilepsy. But 2 weeks down the road, he comes back and tells you, hey, doctor, after your TMS, my seizure frequency has increased. Now you're in trouble, right? So I do not do TMS on patients with history of seizures. Okay, this is very important. All these gadgets, you have to be sure. You have to check. You check, your technicians check because once you spoil one of these, then you're in big trouble, right? It's like the MRI thing. If you miss it and you go to MRI, then you're in trouble, okay? Apart from that, there are no kindling or histological changes that are shown to date, okay? So, single pulse TMS is approved only for research in the US. So in the US, they do not have that kind of CMCT kind of service office utility, but ironically, they have RTMS for depression, headache, and OCD. Okay, there are many international guidelines on RTMS, particularly. Single shot is not a problem. On RTMS, that tells you whether you should be using a certain frequency with a certain power duration over a certain period of time. In fact, you ask our vendors from Neurosoft to be able to give you information on what is the safety guideline, and they're often built into the system. So it's unlikely that during treatment you will exceed any of this, right? So there are many guidelines for RTMS, so not to worry. So it's actually very safe procedure. Okay, it's safe, it's painless, and it's quite effective. For single shot TMS, again, I told you cost versus benefit versus safety, right? To start using the TMS, you need to read up and understand the physiology of the machine interface with the brain physiological properties itself. You need to understand what is cortical spinal function and what are the other descending tracks that you may inadvertently stimulate. And also understand what is the muscle twitch MEP characteristics, some of these, how it is derived, and what it represents in the clinical setting. There are obviously a lot of widespread diagnostic and research applications, but not everything is very, very useful. Often you need to corroborate with other investigative modalities, including blood tests, imaging, even nowadays neurogenetics, right? Genetic screening. And some limitations include the method itself. people don't understand the method. There's the activation, particularly peripherally, not sure where the site of activation is. The findings are dichotomous because the brain is very variable. It can facilitate or inhibit at a short period of time. And some of the findings are, is it really primary problem or is it a compensatory result? So there are many new techniques coming on the horizon to stimulate the brain, right? Including not only RTMS but other types of methods, TDCS, TPCS, and many different methods. And they each have their own advantages and disadvantages. We have to be aware of non-invasive brain stimulation is a developing field, but again, cost benefits, safety must be borne in mind at all times. Okay, this book of mine that I published about 10 years ago needs a revision. Later on, after the break, you can have hands-on, but now we'll just maybe go for a toilet break. Later on, we'll demonstrate these including the coil you can play around with, MEP, thresholds, mapping, root stimulation, phosphines. We do that in a while. Okay, I think that's about it. We finished the lecture, just over an hour. Right, we'll take a 5-minute break. The toilet, while we set up the demonstration now on the normal person, and I think Neurosoft has arranged something for us. And maybe you'll film or you can come forward or whatever way that we can do it.
Excuse me, you the demonstration of normal subject.
Normal subject first.
After that, you have
we'll take a short break.
A short
5-minute break.
Yeah.
We have to set up this thing. Just about this. Often they come in with this, and they will ask us to do a TMS to see if the cortical spinal tract is affected. So you'll be surprised. If you ask me whether in this particular patient the CMCT will be abnormal, I don't know. You'll be surprised. It can be abnormal or it can be normal. Because sometimes the cortical spinal tract is not, you've seen the spikes. You go into surgery, you see the spikes. Cervical cord is very, very small. Very, very small. I think it's even smaller than, it's a bit smaller than my thumb. And these lesions here can compress the cord but miss the cortical spinal tract. It may not be right there, but it may be there also, and you don't know. So they want that information, and TMS can screen that out. You can screen that out, okay? Of course, you will have a situation where you have a situation where you have a very, very severe compression, right? Let me just move back. Sorry. You have this kind of situation, right? Where the cord is like pancake, right? Then you say to yourself, why are they referring this patient for TMS, right? But they still want it. Because they say that, okay, maybe I want to operate on the patient, but I want to first show the patient that the cord is already bad. So after surgery, if it doesn't get better, well, it's too bad, your damage is already there. You see, TMS already showed this kind of MEP, that kind of thing. So that kind of thing. So like I said, the clinical utility, the office utility is largely not in ALS, not in motor neuron disease, or not in Parkinson's disease for single shock TMS. You can try that for treatment, but for single shock TMS, by and large, this is a situation where you want to use the method, like I summarized in this slide. Here, office utility, TMS. So, you ask me, this is the main one. It's complementary to imaging and clinical. The other methods, I don't think is superior at all. Okay, for diagnostic purposes.
Yes, I would like to ask how to determine the motor response when the patient they have the myelitis. Yes. Because the motor response of the myelitis may be higher than actuals of this patient.
You're talking about the threshold, right?
Yes.
So good question. The threshold, it may not be threshold. So in patients with very severe myelopathy, I think that's what you mean, right? You're going to have this situation here. Absent. So later on, we have a subject that's coming and he has myelopathy. And I don't know him, but it could be very severe. You might end up like that. There's no response, absent response. Or it will be a very delayed response, okay? Or a very small response. So this is upper limb and this is lower limb. It could be a very small response that is delayed and the central conduction time will be delayed. CMCT will be delayed. This is normal. Right? So if you get no response, you can't measure central conduction time. Is that what you mean?
But if this patient, they had the depression, yes, and we use TMS for indication of depression and how to... Depression, yes. And we can determine the motor response. So how we
threshold.
can... Yes, so how we can set up the protocol for the patients, maybe we have the limitations of the motor response. It means that at that age, for the woman, maybe we use the 50s intensities like that. I mean like that, yes.
What I suggest is that if you are trying to determine the threshold for RTMS for depression treatment, you can try other muscles. Okay, you can try other, because you know better. You can try other muscles. You can try maybe the EDC, EI or EDC, and look for the threshold. Because if this kind of situation, if you have this very severe type, you're gonna have this. You're not gonna get anything. You can do that. Otherwise, you have to refer to your protocol. It may be so high that you cannot stimulate 100%. Right? You can do a calibrated, maybe a reduced one, maybe half of it, 70, 60. Right? Unfortunately, the protocols are defined by 5% below the active, the active motor threshold, and it's going to be difficult. So you should not stop the treatment just because the patient has myelopathy. You have to come up with a lower stimulation threshold. It is, I would say that's for depression. It's more like the number of pulses that you deliver that's give you the clinical outcome. And more than the how high it is. If it's certain, from my experience, even if it's very, very high, you don't enough pulses, your effect is not going to be that great. Is that what you mean? I'm not sure. You have to find you can't find the method, you got to find the next best method.
Bây giờ này thì cái motor threshold đó là em thường bằng cái giống như là evoke potential, excuse me in Vietnamese.
Yeah, Vietnamese, you translate for me.
Okay. Tức là for motor threshold, you put just like evoke potential and you search for the response of afterpolysis. If you the witness the response of the comes around 50% of normal and for depression, because this is just like apathy of the patient and very inertia, no response, and you have to increase around 120% of the lowest motor response. So that you stimulate by the motor evoke potential, and you see that the pressure, and you see that when the most weakness, you can see first very strong, but after that very weak. You choose that just like 50%, and you increase more to treat depression. It's not the same as the Parkinson. Vì anh giới thiệu về trầm cảm, còn cái tổn thương tủy tôi không biết. Tổn thương tủy thì là cái mới mà bây giờ ông nói là ông vừa rồi nói thì cái này nó chỉ có lợi ích trong chẩn đoán thôi, chứ không phải lấy, anh thấy đúng không? Mà nó sensitive hơn somatosensory evoked potential, liền thế loại kích thích cảm giác á, nó nhạy hơn. Chứ ông không nói là chỉ là phương pháp bổ sung thôi, chứ cái này không nói là điều trị. Tất cả những cái phần sau của ông là ông nói được gọi là chẩn đoán bổ sung cho cái chính xác hơn. Ví dụ như là những bạn chẩn đoán dementia hay là frontotemporal rồi hay chẩn đoán MS hay là những cái tổn thương, và đặc biệt là trong tủy là cái này bổ sung rất nhiều. Okay.
Yeah, what is can you translate?
Okay, explain a little bit. You present a topic very interesting about the complementary tool for diagnosis of many diseases.
Yeah, but a lot of the diagnosis is on.
I know.
Yeah, it's not very.
Complementary.
Yeah, it's not useful in office setting. More complementary. But for cervical myelopathy, I think it's helpful. It's very good. Yeah.
Okay. Excuse me, I have one question.
Yep.
I see in some slide you show that you have the coil you put in the back of the head and you say it's a stimulate brainstem. So I heard that in stroke we have the patient with dysphagia. Okay, you mean maybe the problem in the brainstem. So how we know that coil truly stimulate the brainstem and what the useful tool for?
Okay, the one in the coil.
Yeah.
Okay, I don't know whether this coil can do it, but the method is invented by Dr. Ugawa. Dr. Ugawa is here. You can ask him. But we've tried it, and in some coils it works. Okay, what it does is that it activates a descending volley that probably cortical spinal tract. He showed it. All right, but if there's a stroke in the brainstem, then common sense will tell you that it's unlikely to get any response. Right? So is that what you mean? Or I don't know what you're asking. Right? So you're trying to say that if there is a stroke and you don't know, right, will you get a response? In fact, I tried that method. Okay, not everyone can get it. Right? It's because the brain's okay, it's got a lot to do with physiology. It's not an easy method to activate. I would say that out of every 10 subjects, maybe 5 or 6, I can get a nice. Okay, we can try that later, but it's a bit painful because it jerks the neck. Not everybody can get it. The reason why is that when you stimulate the top, when you facilitate the muscle, you're actually getting a loop. You're getting a loop. Is a kind of a loop, and it facilitates. Right? But here, the facilitation is not so robust for sure. You don't have that kind of interneurons that facilitate. So the response is smaller, and also the brainstem is quite deep, inside. You have to be very accurate. Here, you can roughly get, I told you the spatial resolution with the figure 8 coil or the round coil. It's not so high, but here you have to be quite precise. So it's not so easy. You see, you can get it. Some patients you can get it, some patients can't get it. But in some, Dr. Ugawa has described it. This method you can use it.
Excuse me, you asked a question about dysphagia. Okay, you are a neurologist. I know very well that all the regurgitation from brainstem is enough by both sides. So that if you know the omniculus, phần hình con người nhỏ trên não, thì chúng ta thấy là cái vùng mà hầu họng nó gần cái vùng cánh tay, cho nên chúng ta dùng để trên cái M1 này gần đó mà mình chỉnh đi vẫn làm được như thường.
Nói là ví dụ như cái vùng nuốt nó nằm ở cái tổn thương thân não chứ không phải ở vỏ não này, thì nó sẽ kích thích ở vùng M1, đúng không thầy? Ý thầy nói là vậy, kích thích M1.
Nhưng và hai là bao giờ hai bên both side of the left side and right side will connected by corpus callosum. That means when you treat PMS for tinnitus, you don't treat only the head, vùng thính giác ở vùng thính giác ở vùng left temporal parietal region has you cannot treat only the head. You have to the first session you treat the head with the high frequency just like 10 heads, but 10 session after you can treat the DLPF dorsolateral prefrontal region on the contralateral to treat the tinnitus. Just like that, when you treat the dysphagia, you can treat theoretically you can treat the opposite side of the depression, but you can treat the M1, but near the omniculus for the pharyngeal, oropharyngeal. That's the case.
Ý em là trong cái rối loạn nuốt nó có cái chức năng của tiểu não tham gia trong cái vấn đề đó nữa.
Tiểu não không được em chưa
Dạ.
tiểu não và brain cell nó đi xuống, còn tiểu não là thăng bằng với lại những cái như là MSA,
Dạ.
không phải là của cái
Không,
nuốt.
tại ý em thấy cái slide của ông là ông kích thích brainstem thì em không biết cái cách nào để họ đưa được cái vô brainstem.
For stimulation the brainstem, you should use navigation and the next session on Saturday, Neurological will present the navigation for the cerebellum because you have many patients with MSA, multiple system atrophy. You have to access the cerebellum for imbalance and
So I think you're talking about whether we can stimulate the brainstem, isn't it? But you want to stimulate the brainstem for any reason? Or is it just for research or what? It depends on what you want it for, right? I mean, we can try on you also. It's not easy to get, I'm telling you that. Even with that one, that round, the one, it's not so easy. Some patients you can have it. Because the facilitation is not very, very good on this part. Even if you ask the patient to facilitate with contraction, it's not that nice. It's small. Any other questions?
no more question.
You want to? Okay, so it's no other question. We can try on normal subject. So we really thank Neurosoft for volunteering. And Andre is here. He's got good threshold. I tried it on him today. Lowish threshold, not very high threshold as you talked about. And we'll demonstrate on him. Thank you. First and foremost, thank you so much for accommodating. Wait, let me go to that page. So the height of it can be as low as 4 to 5 millivolts, or it can be very high, sometimes 10 millivolts. So your gain shouldn't be too much, but you can adjust it along the way. Okay. So the impedance is perfect. And where is the point? Draw a line on the oral line. And then find the vertex. It should be 4 centimeters lateral and 1 to 2 centimeters anterior. But in some people, it is posterior. All right? I think they can hear. Point here, and orientation is usually 45 degrees to the anterior line, 45 degrees. Okay, if you go and we do mapping with different angles, you find that 45 is correct. And this is using the focal coil. The lazy way is to use the round coil. Later we show you the round coil. Okay, and round coil, the stimulation is on the side. Not so focal, but it's more photo than the round coil. Alright. Okay, you put it here. Okay, sorry. Here, and then what's the limit? 50. Okay, start with 50. Okay, now it's at rest, at rest. So you see whether there is a resting motor threshold. Okay, already got the threshold. So you can put it below 45. Yeah, 45. It's a low threshold. Okay, can you put it at the definition 50 microvolts? Okay. So that means 0.05. 50 microvolts. So in experiments, they use 50 microvolts, 5 out of 10 trials. Okay, 1. You know. Okay. Yeah, I got it. So 5 out of 10. Oh, it's very good threshold. So I think you got to get on to 40. Very good threshold. Okay, this is about it. Some are absent, some are present. So your threshold, a resting motor threshold is about 45 from 5 out of 10 trials. Okay, so if you want to do RTMS on him, like you say, this is so you might want to calibrate it at just below 45, maybe 2% or whatever. But it's very low. It's got very low motor threshold. Right? So some people are very low, but it depends on many factors: the coil, the hair, the scalp, age, medications, and all that. Okay. So now we go to something comfortable. Let's say good. Now it's 45, right? 40, right? 40. Okay, good 45. Okay, fine. Okay, now at rest, a nice MEP, right? Okay, if you facilitate, okay, facilitate. Okay, now I'm facilitating. See how big it is. Okay, I think you make the game. Yeah, try one more time. So you don't facilitate, right? Okay, now you facilitate. Facilitate. No, okay, okay. Now you facilitate. Facilitate means contracting the muscle. Should be a lot larger. Increase it a bit, 5%. Make the gain small. Make the gain small. Facilitate. Okay. Okay, don't contract. Yeah, don't contract, you don't get anything. Now you contract. Then see, once you contract, it goes up. If you don't contract, you can hardly get very much. Sometimes there is. So your threshold is about 5%, so very low. Very low. But it's normal, about 40 to, most people are about 40 to 80, maybe about 40 to 80. So you're about 45% motor threshold. Okay, so that's the active motor, okay, this is a resting motor threshold. You can also do the active motor threshold, but once you contract, it's a lot more variable. So I suggest the resting motor threshold. So when do you do active motor threshold? So like for example, you ask the question, patient has cervical myelopathy, right? You may need to do active motor threshold if you want to look at the motor threshold. But the problem is, most studies have in RTMS for depression calibrated to the resting motor threshold. So it really depends on your comfort level and your what you are used to using in your setup. So that's usually the case. That's what happens. Okay, so this is threshold. Anybody any questions about threshold?
So it's important to know threshold because, like she highlighted one example, it gives you a standard intensity to stimulate. Okay, not so much as for diagnosis. Okay. Now the second we'll demonstrate to you is the MEP central motor conduction time. They will do the central motor conduction time followed by the central motor conduction time. Okay, we'll use the instead of the F wave method, we'll use the root stimulation method. Okay. But don't forget this coil is a bit curved, so you'll bear with me. Okay, so central motor conduction time, we already got the peripheral motor conduction time. Right? That comes in 20 milliseconds, right? Okay, we try one more time. It can increase to 50. Just double check. One more. 55. Then facilitate. Facilitate is bigger. Facilitate one more time. So it's a lot bigger, but the latency doesn't change that much, but the amplitude kind of increases. Okay, one more. So the latency, the amplitude doesn't change very much. The amplitude changes, the shape changes, but the latency doesn't change very much. So we are at how many milliseconds? 1, 2, 3, 4, maybe 2 milliseconds. 18 milliseconds. Okay, so about that, we move the cursor to the. Okay, now we will demonstrate the neck stimulation to subtract central motor conduction time. Right? So because this coil is a bit curved, I have to do it this way. And where am I stimulating? So this is C7. This is C7, right? Actually, I use a round coil, but I'll try and see if I can use this one first. C7, and then just at C7, just below here, the T1 here. Because this is a small muscle and T1. See whether I can get what we call the peripheral nerve root response. Yeah, try with this. What's the intensity? Here we go. We change the coil. We change to the round coil. So why is it a bit difficult for this one? Because the round coil will activate the nerve root, like through the diagram. It's going to feel like this. It actually activates the root and it comes out and turns. So this TMS cell magnetic start is quite interesting in that it always captures the lower spectral point activation in the peripheral, not the central, in the peripheral nervous system. Same for stimulating the leg as well. The lumbar root as well. So okay, we use the round coil. So the round coil, the point of activation is on the side, not the middle, on the side. Look at it. Yeah, this test it. So this root then should be this side. So when you the middle there's no magnetic flux. So you put it if you put it on the here, you stimulate this side. What happens is that this part just sits right on top of the motor area. And you try this side, and it sits right on top of the motor area. So what you do is that you put it at the vertex, you move left, or anterior, posterior, lateral, medial. This is how you do it. And you apply it on the tangential on the scalp. Later on you can try. So it sits very nicely on the top. So there is a cardinal difference between activating the nerve root and the brain. There are differences. And of course the cranial nerve. Okay, we can we try the root first. Try the root. Okay, there's no of course. There's no need to activate it. There's no activation. It's just direct activation. Make the gain higher. Make the gain bigger. And then you have it. You can see the root there, right? So what you can do is that you can actually turn it this side and see if you can get a better response. Okay. It doesn't change much. Interestingly, see the latency doesn't change much. I'll go to the next one. Increase the gain. No, not the stimulation. That's the gain, the size thing. Gain. Okay, just one more. Sorry. Put it at 60. Yeah, it's very strong. Same thing. So you put the cursor there and you subtract. It comes at about 1, 2, 3. You remove the cursor. So your cerebral conduction time is quite little. 7. Marker is okay. So how many?
6.
What's the first? 13. So 13 minus just now because 18. 5 milliseconds. Central conduction time. Usually about up to 7.7. So about 5 milliseconds from here to the cell. So that's central conduction time using the nerve root stimulation method. Okay. So let's say you get cervical myelopathy. What happens? Right. First of all, the peripheral motor conduction time may not change very much, but the central motor response, the cortex muscle latency will be increased. So that when you subtract this, you get a very prolonged central conduction time. So, or sometimes you might even have nothing, no response. It is severe cervical stenosis. Okay, now since we have this coil on, why don't we show you how to stimulate using this coil on the left hand. So when you're stimulating on the left hand, like I say, you've got to put it on the vertex, right? You've got to put the coil, the current got to run this way, run backwards, so that the induced current in the brain is anterior forward. Okay, so priority right hand rule. You use this one. I'm going to call it. The coil will be this side, the B side. The B side on the vertex. Okay, if it's the leg, you want to do the leg, you want to activate the leg, right? Then you're going to put it more anteriorly. Right, so you can move it around here a little bit to the right or a little bit to the left. Okay, a little bit to the right, a little bit to the left. Okay, let's see whether you can get it. How many are we? 50. Okay, now at rest, whether we can get 80. Okay, 60. We got it again. So, okay, now you facilitate. Okay, now it's contracting the muscle. Oh, it's much bigger. How much bigger is it? Huge. Right? You don't facilitate. Very small. So once you facilitate, it's like, maybe 8 to 10 times bigger. Once you facilitate, much bigger. Okay, so this is another method of using it. If you want to use the leg, you want to do the leg by 30. think so. You can show the leg. Leg, very difficult. For a low threshold person like him, you might be able to get it at rest. Okay, maybe Dr. You can try the leg, don't mind. Right? Then we try at rest. Okay, the leg will come at 40 milliseconds. 40 milliseconds. So if this one comes at 20, this one comes at 20, this one comes at 40, right? Because double the distance. So at 40 milliseconds, you're going to use first one square is 8 milliseconds. So you'll come out the fourth square. Fourth grid. And the MEP is a lot smaller. Okay, maybe half the size of the hand. Okay, so why half smaller? Why a lot smaller? I tell you honestly, we are not activating all the cortical spinal neurons. We're only activating as much as we can activate. Okay, same thing. Left leg at rest with the coil on the head, but more anterior. Okay, more anterior for the leg. If I can get. Because sometimes leg, some people you can't get it, but at rest. You're not much. That's the sweep. 5, no, 2 to 8. 8 milliseconds to do this. No, but then also can. Then is okay. Then is okay. Then is okay. You'll come out the force. Okay, try it. Okay. Nothing much. Then is okay. No, 10. Very short. Let's try it. Maybe don't do it. Yeah, I'll do it. Yeah. Okay, later you I tell what do it. I'll show you. Okay, got something now. Alright, got something there. Yes. We turn up to 80. Something. Yeah. Okay, so now you facilitate. You press down. Actually, for leg facilitation, I tell you honestly, I like someone to put the hand there, put the finger there. They do that. But you're actually the other side. Yes. But we try. Sometimes it works. I like to press it there. And then you activate now. Whoa, so much bigger. It's so much bigger. So it's God, same thing. So for him it's easy, low threshold. And even for the legs it's correspondingly low threshold. So that's easy. Okay. The next bits will show you so central motor conduction is the same. You're going to stimulate the back of the spine, the lower back. You want to do no problem at all. Okay, we can do it this way. Okay, this is number 5. Number 5. Okay, go lower. Go 17. Number 5. Go. This shot. That's you should come at about. Yeah, I'll turn the coil and see the other side. Let's try it out. Yeah, move it down. It doesn't change the response. But it doesn't change very much. Doesn't change very much. So again it searches for the lowest point in the so there's another way of practice. But okay, I think we don't do too much quite people. Okay, then we can do the maybe the the cortical silent period. So cortical silent period is during activation. I normally ask the patient to try and activate as much as possible. Although people tell you, oh, 20% is enough, not really true. Try and activate as much as possible, using all the strength, and then give it a bit of rest, and then do the next pass. So cortical silent period, not easy to obtain from the other muscles. Usually the hand muscle is the key muscle. And it's about maybe 50, maybe 70 seconds in duration, and sometimes longer, sometimes high, but very high. And if you increase the intensity, you can actually increase a little bit. Yeah, I won't use it. I won't try to use cortical silent period for diagnostic purposes. Okay,
What's the mix of
we can use it. So okay, there you go. Yes, okay. Okay, next, see, you can increase intensity, the that rate increases a little bit in duration. Okay, next one. It increases a little bit. But you reach the maximum, you won't go to zero. You go to 100. Okay, I think it's about right. So you see how beautiful it increases in intensity. So I try to facilitate maximum intensity. You go to 100 about there, you can't go beyond 100, right? It's too Tesla machine. Can't go beyond 100. So where do you measure the cortical silent period? We will measure from the point where we the cursor. Where would you measure? Probably there. Yeah. Then the first point is some people don't like to measure from the point. Yeah, where's the first point? First, the beginning of the time period. Yeah, one. No, back. No, back. Left side. Show. Left, to the left. Shoot it to the left.
the beginning is
So the beginning.
stimulation point.
Yeah, the beginning of some people use to measure. So the offset point is quite clear, but the beginning point, again, because the EMG curves up. So some people use the start of the include the MET duration inside, but I often measure it at the point in front. Yeah, there you go. Yeah, there. Yeah, and you use that one. That one, yeah, correct. And you use that one as the first point, and then the second one is the and the second one is the end. Right. Second point is the one where the EMG restarts again. So this is cortical silent period, and interestingly, it comes after the MET. So people argue what is this thing, right? Is it what is it? It's actually a loop where the potential goes through the inhibitory interneuron, right? Interneuron, whether it's some people say it's what basket cells, cell type, not sure, but correlation is with kappa mechanism. So that's cortical silent period. Okay, we'll show you the motor imagery. Motor imagery. Actually, what is motor imagery? So you can have so it's more fun, but I won't say you can use it in patients who have psychogenic or functional weakness. But in some experiments, they use it to look at motor control. So motor imagery is that when you have MET or stenocyte at rest, you don't move it, you imagine the movement, right? So it's called movement imagery, right? And in rehab, movement imagery is actually a rehabilitation strategy where you don't move it, but you practice on your own. Okay, so you are free and then you practice. You're supposed to change clinical classes, but single stimulation, you can actually show that the motor response is somehow not a lot larger, even without movement. So that's movement imagery. So it's called imagery and imagine. So imagery. So if yeah, just show look at go back to end. Yeah, blue. Yeah. Okay, we find maybe a bit higher. Okay, there you go. Okay, you imagine you going up. Imagine your finger is coming up. I'm giving you extra cues. Right, encouraging you, okay, all the way. And there goes boom. So it shows you that the motor program is actually active, is an active thing, it's the real thing, it's moving all at real time. So this is motor imagery. I'm coming quite late. Okay, now I will show you the we'll show you the phosphine threshold. If you want to try later on, you can try. So I'll show you what is phosphine threshold. I think we'll change the color. We'll change back to the round color. Okay, phosphine threshold is I think this one. Go back to the phosphine threshold the last bit. Later on, we can try on the last bit. Because you take a 5-minute, 10-minute break, you have a patient, and then you can try. It's supposed to end at 5. So the phosphine threshold is a threshold where you stimulate auditory cortex, you close the eye, you see a flash. Very fast. Maybe 20 milliseconds. I can't be 20 milliseconds. 200 milliseconds. Because 20 milliseconds, you don't have enough time to process. But what you see is that you will see a brief flash of light, and actually you can map it. Alright, you move it a bit to the right, you might be on the right, you move it a bit to the left. And people have used this to study migraine threshold. And that is the migraine with aura patients have been shown to have lower threshold of phosphine in comparison to people with no migraine aura. Or even patients with migraine with no visual aura. Okay. So phosphine threshold, unfortunately, he can always tell you that he sees it, but you don't know whether it's bluffing. Alright, but I just show you what it is. It's a very brief flash. Later you can try on yourself. If you're okay, none of you have epilepsy, you can try on yourself. Okay, so what we do is we put this foil alright, this is and it's angled over the occipital cortex. Right, you put it about 60. Yeah, 60. Close the eyes. Okay, no motor response. Okay, only half people can see it. By the way, normal people, how they can see it? Got it? So you see the flash. So about 70 is phosphine threshold. So like a bit like an aura that you see. Okay, thank you, Andrea, and